Mahesh, are we live?
Yes, sir. We are live.
Okay, let's go. Okay. Good evening, everyone. My name is Dr. Krishna Sheshadri. I'm an endocrinologist from Chennai. What I do is I help Wipro put together this particular program, a platform that enables physicians to interact during the COVID pandemic and provide
I think Dr. Sheshadri had a power failure, probably.
Okay. I'm sorry.
Yeah, back. Yeah.
We lost power in my place. I'm sorry. So, but I'm back. So GCCMC is short for Global Coalition for COVID-19 medical care, and this was put together by Wipro as part of its CSR activities. Wipro has several foundations, but Wipro is also involved in COVID in a big way in its response in terms of the outreach, in terms of providing supports to people, in terms of creating a hospital in Pune that takes care of COVID. We've also helped create early learning modules for physicians who have otherwise find care of patients with COVID difficult. So we have, along with PHFI and AHPI, created early learning modules that are going on as we speak, and it's been on for the past 4 weeks, and it's going to continue for another 2 weeks. We're also looking, but the most important thing is that GCCMC is a facilitator of dialogues between experts and people. So the platform has created means that will provide a non-pharma based, no conflicts way for people to interact, where nothing is held back. And Wipro has no intellectual or other intent in this other than to bring physicians together. So we've been doing these webinars that are somewhat different in that they bring eminent personalities across and locally, but also created in terms of a dialogue. Not many slides, but allow people to crowdsource questions, get their answers cleared. And today we have an exceptionally great panel today. And I want to introduce Dr. Abdul Ghafur from Chennai, probably one of the most active infectious disease specialists I've ever seen. A very somewhat different from the usually said it a lot. You know, I work with John Shagrin and Jim Mallow and others in the US, but Dr. Ghafur is very different. And his enthusiasm brings that he brings to this particular program is very unique. And he is our moderator for today. So Dr. He's from Chennai. He's the author of the Chennai Declaration. His work on antibiotic resistance is tremendous, and he's got a lot of accolades. But on the whole, whenever I see the way he posts, with the way he talks, I can see his empathy and compassion for patients and his fellow human beings. And I think that is probably the greatest tribute that a physician can get. And Dr. Ghafur, welcome. It's all yours. You have a great panel. You have all the time, and you have no pressure to do this. Dr. Ghafur.
Thank you, Dr. Sheshadri, and thank you, Wipro, for your initiative in organizing this meeting on an important topic called the COVID vaccine. First of all, I do not have any conflict of interest with any of the vaccine manufacturing firms to disclose. A simple virus called SARS-CoV-2 imprisoned the whole world for a prolonged period. The enemy was unfamiliar, and we had no weapons in our armamentarium against this enemy. We hid ourselves in our own fortresses. We tried to wash away the enemy with alcohol hand rub and soap and water. We used cloth masks and plastic shields as our armories. And then we prayed to all our gods to deliver us with COVID vaccine. And all the gods delivered us with one COVID vaccine each. Now, thanks, we have so many vaccines in our hands. But are these vaccines all equally effective? Are they equally safe? Which vaccine should we use? Should we vaccinate every individual in the world to end this pandemic? Are we following all the ethical process, the transparency in the regulatory process and research? And today we have three eminent speakers, very eminent speakers in their own fields of science. Dr. David Heinemann, Dr. Jacob John, and Dr. Anand Bhan. They are not only experts, they have threads, their own paths in their own respective fields of science. Their opinions are respected across the world, and we are lucky to have them here as our expert panelists. First, Dr. David Heinemann is one of the most authoritative infectious disease epidemiologists in the world. He served as the Deputy Director General of the World Health Organization. He was the chairman of the Public Health England. He's currently heading the Global Health Security Division of the Chatham House, that is the Institute of International Affairs in London. He has so many awards to his list, including the Commander of the Order of the British Empire. Dr. Heinemann, would you please give us a short introduction on how the scientists, politicians, and the industry came together in an amazing way to develop COVID vaccine in such a short period? David.
Thanks very much, Abdul, for that kind introduction. And yes, as you have said, it's been remarkable how industry, academia, and governments have come together to make sure that we have the vaccines that we need today. And those vaccines are very diverse, as you know. As we all know, the ACE2 receptor on human cells is the target for the virus. And that's where the immune response begins. The spike protein locks on the receptor, enters the cell, reproduces itself, is released, and then ingested and processed by antigen presenting cells. And there's either a T cell or a B cell response, or both in most cases, with antibody production. So that's the way that this virus is doing its job around the world in preserving itself and in spreading from person to person so that it can reproduce. And vaccine manufacturers and academia have come together with support from many governments around the world, either through direct contributions to the companies or indirect through advanced purchase commitments to increase the number and amount of research going on in vaccines. And as Jacob will know, and all of us know, it's quite incredible to see how many vaccines are being developed. Generally, it was one vaccine every 5 or 10 years. Now there are all these new vaccines coming out. And just to review the types of vaccines so that everybody again is on the same page, there are the messenger RNA vaccines, which are the genetic material that is injected, surrounded by a lipid that permits that genetic material, the RNA, to enter a cell, produce spike protein, which then causes the immune response. There are also traditional vaccines with adenovirus vectors, which are being used. The vector reproduces in humans, and onto this vector has been grafted the genetic material necessary to make the spike protein. Those are live vaccines, and they're vaccines which reproduce in humans. Then there are the inactivated virus vaccines, and also some attenuated virus vaccines are being developed. And finally, there are virus particles that are to imitate the spike protein, which are also being used. So all of these different vaccines, Abdul, are being developed at present. And so far we have 2 with emergency licenses in many countries. We have a 3rd which is coming through, and we'll have many, many more as time goes on. So Abdul, again, thank you for having invited me to participate, and I'll turn back to you.
Thanks, David, for giving us a very short and crispy introduction to the vaccine development. Now we have Dr. Jacob John. And Jacob, sir, is one of the most illustrious virologists our country is proud of. He's a pediatric infectious disease specialist and a clinical virologist. Dr. Jacob John is well known to express his opinion in a very bold manner. And his opinions are very well respected by our policymakers. Sir, please explain to us, should we vaccinate each and every individual in this world to end the pandemic?
Thank you, Abdul, David, Vijay, Krishna Sheshadri. Is Anand Ban will be arriving shortly, I hope. Is our audience mostly medical people or a mixture of medical and non-medical people?
Mostly medical, majority,
Mostly
yes.
medical. Okay, so I don't have to worry too much about jargon getting into the conversation. Thank you, David, for that succinct summary of different vaccines. Let me just classify them that till now we have been using antigen vaccines. The novelty today is that we are not using antigen vaccines, but we are using the genetic code for the antigen and making human cells make the antigen and then the immune system respond. It's a very clever idea. The messenger RNA vaccine had been in use for a number of years for personalized anti-cancer immunization. So it's not absolutely new, and its safety is fairly well established. The only worry that I had was whether, as David said, the ACE2 receptor is for angiotensin 2. The molecular mimicry of the virus is like angiotensin 2. Will there be any crosstalk between angiotensin 2 and antibody against the receptor binding site of the spike protein? I've cleared, the experts say no, don't have to worry about it because that mimicry is not at the molecular structure level, but more of the folding pattern level. So you don't have to worry. The vaccine will be, if you can show it to be safe in a clinical trial, there is no worry about it being of any problem. And of course, we know that people with cancer have already tried this vaccine, this methodology, and found it pretty okay. Now, Abdul's question can be reworded as to what do we want to be achieved using COVID vaccines? Now, preventing severe disease and the risk of death is the obvious first line that we can get from the vaccine. And that is why the emergency use authorization is a good tool to target the highly vulnerable people, to protect them, frontline healthcare workers, essential service people, those above 65, those below 65 with comorbidities. So that is one. That is, I would call that the healthcare preventive medicine approach. Okay. There, we are giving to people who are vulnerable. So we know that they had not been infected previously. If they knew, if we knew they are infected previously, there is no need to give them vaccine in a hurry. Next year, we will think about whether their immunity is lasting like influenza vaccines immunity, then we will think about that. They are not at risk now for any more infection, disease, and severity, mortality, etc. The second opportunity or second approach for using the vaccine is a public health approach. Your question contains that that's it's implicit. Why do you want to immunize a larger segment of the population to create their community immunity level so that the infections speed will slow down to control level? So for that purpose, and since vaccine would not be available in huge amounts to cover the whole population, it would be wise to say that vaccine will be given to these kind of people first, and then coming down to other people, other individuals on the basis that they have not been infected and known to be infected in the past. And their infections are all recorded. They're all in the computer database. They need not be vaccinated at all. Some people may come in and say, pretend not to have been infected, but the database is available. It's a matter of how smartly we can use that database to screen people. The others, of course, are the target for the public health use of vaccination. But let me tell you that the public health use of vaccination is not just simply giving vaccine. We need to have monitoring techniques. What you don't measure, you're not controlling. So you need to measure. So you need database as to what is the epidemiology, what is the incidence rate at a given time. Is the incidence rate of infection, not disease alone, is declining? So those kind of issues are a little more complicated. However, for either of these, many countries are not prepared. For example, India. India does not have a formal public health department. So in the absence of a public health department, a whole lot of what should be public health activities are either not done or done in an unsatisfactory manner. For TB control, there is a silo, TB control silo. There is malaria, there is a silo. Even EPI is a vertical program, and EPI diseases are not under.
Ishwari, Abba.
Pardon?
It was interruption, sir. It was interruption.
The expanded program on immunization, EPI, childhood vaccination program, targeting childhood tuberculosis, diphtheria, whooping cough, tetanus, measles, polio. Polio, of course, is under eradication mode, and then we have excellent surveillance data on that one disease. Only on that one disease we have good surveillance data. All the others are quite unsatisfactory. 21st century, there have been so many episodes of outbreaks, I would say epidemics of diphtheria, which underlines the fact that we don't have good surveillance. These diphtheria outbreaks come out in the open only because of media news, mostly. Anyway, so we don't have to vaccinate everyone. We can be selective about it. But if you're going that way for public health use, we must be well prepared for monitoring the trajectory of the infection. If we are not going to do that, it'll be a ritual of distributing vaccine, not knowing what we achieve, even though the purpose may be controlling of the disease. Okay, let me stop here, and we'll wait for more questions later on.
Thank you, Dr. Jacob John. We have Dr. Anand Ban, and I would like to introduce Dr. Anand Ban as an Indian celebrity. If you want to see him, you have to watch TV every day. He's on every TV channel. He's not a film actor or politician. He's a bioethics expert. He was the past president of International Association of Bioethics. And we respect Dr. Anand Ban for his courageous stand that he has taken on several issues related to vaccine development and licensing process. Dr. Ban, would you please tell us on the importance of maintaining transparency during the vaccine trials and the regulatory process, and its implications on the important issue of vaccine hesitancy? Dr. Ban.
Sure. Thank you so much, Abdul. First of all, a pleasure to be part of this panel, and also a privilege to be on the same panel as David, Professor John, and yourself. Thank you for this opportunity. So as Abdul had said, one of the issues which was suggested I could maybe touch on briefly, just to set the stage for our discussion, in the panel is this whole issue of, what kind of transparency issues are relevant, but especially because we are talking about vaccines which have been developed at warp speed, as is commonly said, especially in the context of India as well. Our experience through this pandemic has sort of been sketchy on the regulatory process. A good example for that is the process for drug regulation. If you look at several repurposed drugs which were allowed by the drugs regulator under an authorization for restricted emergency use, which by itself is the first time the CDSCO has used this kind of a categorization. It's been often the case that it's been unclear on what basis these decisions have been taken. If there is enough data, if this data is in the public domain or not, whether if there were clinical trials conducted, what were the numbers, etc. The membership of the committee involved has not been made public. The evidence which is used to make these decisions has often not been made public. And that makes it a bit difficult, and also, raises a lot of concerns about processes, which I think is important to highlight, because we are starting to see some of those concerns also come true in the vaccine landscape. So then why would we want transparency? I think, transparency in many ways is extremely important because it has a direct implication on trust. So Abdul had a question towards the end saying, how could that be linked to vaccine hesitancy? If there is a lack of confidence in the process, then a lot of people will have questions about the vaccine, how these vaccines were approved, and that might decrease their willingness to take the vaccine, and that obviously can have implications from a public health perspective. So the kind of transparency we are looking for is one about the trials. Often it's the case that the only information we have in the public domain is what is on the clinical trials registry, the CTRI in India. But there is not enough known about design, about protocols, about the statistical analysis plans, about what have they written about interim analysis, criteria they might use for early halting, results, data, outcomes, especially around safety, efficacy, participant level data. Who are the members of the regulatory bodies which are involved in these decisions, what criteria they are using for making decisions about allowing market authorization, under what section of the law are they going to do it, etc. Some of that slowly has started to come out, but a lot is still not known. We are obviously expecting this transparency from vaccine developers. So those would be the source pharma companies, because many of these are MNCs which are involved in vaccine development, but also the manufacturers. So many of these are actually being produced by Indian companies such as Serum Institute, Bharat, etc., which have these large manufacturing capacity and have been, major sources of global health supply for other vaccines. But also we are expecting transparency from regulatory authorities. CDSCO, ICMR has been during this pandemic involved in the regulatory landscape as well, the ministry, as well as participating research institutions, some of which actually have never done clinical trials for vaccines, but for some reason have become clinical trial sites during the current vaccine trials. And that by itself also does raise some concerns, because vaccine trials are not easy to conduct. You need to have some capacity to be able to run this, especially during a pandemic. Everyone should be expecting this transparency to be there. All of us who are academics, those of us who are practitioners, whether you're a physician, whether you're a public health professional, a lot of civil society members are asking for that. If you are just going to be a potential recipient, you would also want that kind of transparency. In fact, Abdul and I are fairly active on Twitter, and Twitter in many ways has been functioning as a independent committee, with a lot of critiques coming, and that sometimes asks difficult questions. But maybe we should have actually that happening in the public sphere, with more information coming as demanded. So hopefully these are the kind of things we will see more of, that there will be a voluntary sharing of data and public reporting. There is publishing of data and not just claims by press reports or press releases, that there is an adherence to transparency standards, some of which are already written up earlier for industry as well as for academia. We also want to have transparency so that we could potentially avoid any pitfalls like politicization of the regulatory process, where there might be political pressure which might bias outcomes, might lead to a decision while still data is not yet enough in place. And that could potentially obviously also lead to a lack of trust or an erosion of trust. Already there is some element of vaccine hesitancy concerns about the fact that there's been a lot of speedy development. Now that does not necessarily translate that there has been shortcuts done from a scientific perspective, but at the end of the day, you have to build confidence in the process so that there are more and more people who are confident that when a vaccine is allowed for mass usage, that it's gone through proper checks and balances. And hopefully we will see more of that. There have been already some surveys which have been done, which indicate that there is some element of doubt about the vaccine and perhaps an unwillingness to take the vaccine among some segments of the population. And that should worry us a lot. And it's not, I would suggest that we don't characterize everyone who has doubts about the vaccine as being necessarily anti-vaccine or an anti-vaxxer, because some of them have genuine concerns which need to be addressed from a public engagement perspective. And if we do that, then I think we will build more accountability in the system. We will ensure that there is more trust, and it will also help us know, how these processes are done, and ensure that these systems are then institutionalized, so that whether for this pandemic, whether for any future one, whether for any drug or vaccine development in the future, we have standard mechanisms where there is more and more information available for independent scrutiny. And these are not decisions which are taken within closed boardrooms, but are available for all of us to follow. And you've seen that happen with many regulators who actually live streamed some of their decisions and their discussions. And I think that does build some element of confidence, because all of what is being discussed is available for anyone else to view and and develop a viewpoint on. And I think there's nothing which stops us from doing that, especially now with more and more technology being used. So I think any excuses companies might have about competitors taking advantage, using clever language that participants' privacy needs to be respected, etc., can easily be countered. And I think if we can work together as stakeholders who are invested in this idea, and especially given the importance of responding to the pandemic, that we all demand for more transparency, that might actually help in the process of building more trust in science and more trust in a future vaccination effort as and when it is launched. So I think I would certainly make the appeal that we all consider this as being important in the interest of science and more trust building in science. I'll stop there with my comments here just as an introduction, and then maybe more for discussion. Thank you. Abdul, I think you're muted.
Yeah. Thank you, Dr. Ban. A recent survey by the local circle survey agency among 18,000 Indian citizens revealed that 69% of the Indian public want to defer the COVID vaccination. They did not say we will not take it, just defer the COVID vaccination. I conducted a survey among 1,400 healthcare professionals in the country. 45% told will immediately take the vaccine, immediately when it's available. 55% wanted to defer the vaccination. In that 55%, 7% told we will never take the vaccine. They are vaccine deniers, 7%. But majority of the individuals who want to defer the vaccination believe in the vaccine. They believe in the science of vaccine. They believe in the COVID vaccine. They just want to defer the COVID vaccination for 3 to 6 months or more. So they are just hesitant to take the vaccine. What can we do to improve the vaccine confidence among the public and among the healthcare workers, especially among the healthcare workers, because India is going to vaccinate 1 crore healthcare workers first. Any hesitancy among healthcare workers may percolate down to the public. So we need to make every effort to improve the vaccine confidence. Dr. Heinemann, what are the strategies the UK government is following to improve the vaccine confidence among your healthcare workers and the public?
Thanks, Abdul. And I think Dr. Ban said exactly what needs to be done and what's being done in the UK and other countries, and that is transparency. Transparency not only in what to expect when you're vaccinated as opposed to the side effects, but also what to expect from the vaccine itself. Presently, we don't know whether this vaccine actually prevents infection, as Jacob said. What we know is that it prevents illness. It prevents serious illness. If it prevents infection also and prevents carriage of the virus in the nose, then we can begin to see a public health impact as well. But what's going to be important moving forward is transparency, and this includes with health workers. health workers need to understand that if they're vaccinated, they still need to wear protective equipment to protect others in case they're still carrying the virus after they've been vaccinated. So until we understand all of the characteristics of these vaccines, whether or not they do provide 100% or greater prevention of infection, we can't really address we can't really permit, for example, health workers not to wear PPE, just one example. So that's an example of where expectations must be met in transparent communication with people. For the elderly and for those with comorbidities, this will prevent illness that will eventually possibly have a fatal outcome with you, so you should take it. For health workers, you should take it for the same reason, understanding that you will still need to wear PPE until we understand more about the vaccines. And many countries are providing weekly an update of how many vaccines have been given, as well as information about side effects, what side effects are occurring, so that people can expect those side effects, which include muscle aches and flu-like syndromes in many cases. So back to you, Abdul, and thank you for the question.
Professor Jacob John, sir, what is your opinion? What can we do to improve the vaccine confidence in our country?
Well, I've worked with students, colleagues, public in various fora, and I realized that people either know by logic in the cognitive domain, they ask questions, they figure out, they want data, information, etc., and they make up their minds. But the majority of people actually go by trust in the doctor or in the person who gives advice, and the trust is in the trust, faith, comfort. It's more on the affective side, and the right way to approach this is to give people transparency is the key word to create trust by giving data, information ahead of time before the social media and the regular media come up washing a lot of linen in public. And that shakes the trust of people, and they begin to suspect that somebody somewhere is hiding something. And so let me see what other people are doing. That is I defer because I want to see the trend. I want to see how people, so that can only be addressed by credible, authoritative, authentic information being passed on. Again, we don't have a platform of that because when politicians speak, it becomes a party affair. If cinema actors, celebrities speak, then you say, hey, who paid the money to speak? So transparency must be created. We have to find the right way of communication. The idea of social vaccine when we faced HIV/AIDS, inform people everything. Okay, sex was taboo in conversation, but we threw it open and talked about condom and marital fidelity and be good. If you can't be good, be careful. Kind of, the messages went in, and people took protection again. I mean, for themselves and their families, and that was half the battle against HIV/AIDS. So today, we are almost 1 year into the pandemic. It's a bit late. Even now, it's not. It's still worth giving authentic and authoritative, public, transparent, all information good, bad, and the ugly, so that people will trust you. That, as you know, that is what I've been doing through writing. I'm not I've never written in newspapers very much in the past, only in medical journals. But I have taken as a mission to give the public through I write, and I get a lot of questions from the public, and I hope I'm creating trust in them to accept whatever is scientifically approved by uh, the vaccine trials.
Thank you, sir. Dr. Bhan, last week, our health secretary, Mr. Rajesh Bhushan, made a statement. Vaccine hesitancy is an important issue. The central government, state governments, and vaccine manufacturers will do everything that is necessary to improve the confidence, vaccine confidence. That's a very positive statement from our government. How can our government utilize social media to improve the vaccine confidence? How to reduce the misinformation? How to give a positive message and transparent message to convince the healthcare workers and public? Because social media is a very important platform for improving vaccine confidence.
Absolutely. I think, it's good that the government is recognizing that ensuring that you are transparent about some of elements of this is important. At least there is an intent. But that also requires you to, respect the other party, which is to say that you don't infantilize the audience. You don't assume that they don't know. You also don't assume that, any question they might have is not relevant, which is to say that there has to be an open idea of engagement. And part of that is a social media strategy where you put out the facts. You talk about what is being done, what is the rationale for that, what are the processes involved, who is involved in that, and why are certain decisions taken on based on what evidence. Now, sometimes that might be a lot for social media because social media typically has smaller updates, but you can sort of section it out in a way that there is a clear strategy to communicate and to make available information, and that information is not only available to a select few, it's available to anyone who wants to take a look at it, and then you engage on that. If there are people with concerns, you also engage on that. But that, I think, requires an understanding and approach which values public involvement in decisions, which understands the requirement for public engagement. This is not unique to COVID-19. This is something we've seen with past pandemics, that it's extremely important for us to be forthcoming with the science. There is also a science to public engagement. It is not just a matter of putting up updates, but actually thinking it through and then also evaluating what is working and then going back to the drawing board if it is not. Professor John was talking about the fact that scientists like himself have been going out in the public domain and writing. Many of us have been making efforts through social media, and all of us are supportive of science. We want science to succeed. We want science to contribute to public health. But at the same time, it's important for us to also serve as sounding boards, to also raise critical questions with the intent that will help us all know better what is being done and how it is being done. So I think social media can be a good platform for that, but that also requires a willingness on both sides to sort of engage duly for that. The other issue being that how do you do it, who do you do it through, and ensuring that they are equipped with the skills to be able to have content knowledge as well as the updated information is important, because sometimes we see that the information which is put out is either too succinct, too brief, or is gone through so many filters that you barely get enough detail, and that is not going to help in terms of engagement. And if you do more engagement, it might help with the misinformation part. All of us are worried about what we see on WhatsApp and what we see sometimes being shared in terms of magic cures, in terms of claims around what is working, what is not working. And you need to respond to that, because at the end of the day, you want more facts out there.
Thanks, Pawan. Dr. Heinemann, we have got a question from the audience. May I ask what percentage of the healthcare workers in UK or England have consented for vaccination, please?
Thanks very much, Abdul. Yes, that's a good question. And what we know from the past is that just over 50% accept the influenza vaccine each season. And that's a different vaccine than this vaccine. Of course, it's a different disease, And in the case of influenza vaccine, health workers are encouraged to take it to prevent sickness among themselves, but also to prevent transmission. With this vaccine, it's to prevent serious illness. And though I haven't seen the recent surveys, it's pretty clear that many health workers understand that this vaccine will prevent serious illness and that they should be taking it. And I would anticipate that there are more than the number of people, the 60% who take influenza vaccine. I would think it's higher. But again, I don't have the most recent survey results and I can't give you an exact answer on that. But I'll be happy, Abdul, if the person in the audience wants to send an email, I'll be happy to get that figure and send it off to her or him.
Yeah. Thanks, David. Professor Jacob Jones, sir, what percentage of the Indian public should be vaccinated to end the pandemic and to prevent future epidemics?
To prevent?
To end the pandemic and
right.
prevent the future epidemic of COVID.
The end the pandemic, actually, in the beginning, a lot of people were saying, based on the basic reproductive number, that when you reach the herd immunity level of 65, 70, 75%, the virus will disappear. That was a message that came through in the very early times of the pandemic. And I have been writing papers, publishing information in scientific and journals saying that no virus in the past has ever done a harakiri. However much people get infected, so the 65-70% is not valid. Why? Because every year we are producing some 150 million newborns, and the susceptible population is also growing. There is a backlog of people who did not get infected in the past. So together, that volume is more than sufficient to keep the virus as an endemic virus in the community. So when you say end the epidemic, end the pandemic, meaning end the epidemic in country by country by country. So in each country, if you want to end the epidemic and shift it into the endemic mode, the same figure of approximately 65 to 75% herd immunity, that is the proportion of people immune in the community, should be achieved reasonably well distributed, evenly distributed. Okay, so do we know the current herd immunity level? No, we don't. Because we have reached the peak of the epidemic curve in the 3rd week of September, and since then we are more or less steadily, the epidemic curve is coming down, we can assume that at the peak level, at least half of that herd immunity level were immune. Otherwise, you wouldn't turn the curve down to the peak. Okay, the curve is rather like a mountain or something. If you draw a vertical line at the peak level, there is left-hand side area under the curve is number of people who are infected, and the mirror image will be on the right side, area under the curve, people getting infected. Okay, so if you turn the corner at the peak, approximately half of the number you asked for, what herd immunity will it require to end the epidemic? Okay, so I assume with this kind of a logic that at least 30% had been infected at the peak level. We are 1,380 million people. So 30% of that is 5 500 million?
Yeah.
Something like that. Okay, in that order of magnitude. How many people have been known to be infected in the country? 10 million. So we have this, gap of information. We don't have good studies to tell us where we stand in terms of the current herd immunity level. The two ICMR antibody surveys are done by using two different antigens. So they're not strictly comparable. You know, antibodies tend to decline over a period of time, 2 months, 3 months, about 50% of people will not show antibody levels, binding antibody levels. That does not necessarily mean that you have lost your immunity, protection against the disease. No, but the way we measure, it's not very, very reliable in terms of measuring the real proportion of people who have been infected. So the correctional factor given by the ICMR investigators, the first zero survey was quite large. You know, you multiply by almost 75, 80 times because of the comparison between the survey data and what was known at that time as to who had been infected. The second survey pegged that down to maybe about 30 times. So if you apply the 30 times to 10, it is 300 million. Okay, if you apply the old 80 times, it is 800 million. So somewhere in the middle, according to the epidemic curves, turning the peak and coming down, we have had a huge number of population already infected, 80%, 90% maybe subclinical. And, you know, every country in Europe and North America, Canada, can be looked at as two countries. A country of people above 65 years of age and a country of people below 65 years of age. India is virtually a country of people below 65 years of age. So therefore, we cannot compare directly on any kind of information between different countries. Be that as it may, recently there was a large outbreak in the Indian Institute of Technology, IIT in Chennai, of young people, which means that there are a lot of youngsters who have not been infected in spite of the fact the peak is behind us. And so if they let their guard down, you have a micro epidemic in that environment. So every university, if it reopens, would expect a micro epidemic in that environment unless strict discipline is used, universal mask wearing, some kind of physical distancing. If you wear mask, at least 2 feet of distancing. When you eat in the cafeteria or in the mess, you will be removing the mask anyway. There you should not sit side by side and eat. You should keep at least 6 feet difference gap between people who are eating. All this kind of discipline, the institutional heads have to learn and to teach and apply this strictly in educational institutions. Okay, so so it's not a simple scenario. So we cannot let our guard down. In spite of the fact that we think about 30% I said was in September, then October, November, December have gone through. So what percentage? Minimum 50%, probably 60%, because the epidemic is steadily coming down. which actually means we never flattened the curve at the first instance. Unlike Italy, Germany, UK to a certain extent, South Korea, Taiwan, Japan, a lot of countries, the first wave was severely curtailed. And therefore, they are getting the second wave much larger than the first wave. I don't think we will have that problem in India.
Dr. Ban, what is your opinion about vaccinating all Indian population? Our government is going to vaccinate 30 crore high-risk individuals, 1 crore healthcare workers, 2 crores of other high-risk individuals like policemen and teachers, and then 27 crores of public age above 50 or below 50 with comorbidities. What about the rest of the public? We have got 100 more crores to vaccinate. We have got 135 crore population in India. Will vaccinating 30 crores be enough? What is your opinion on that? And how are we going to convey this message to the public?
Yeah, so, again, I'm not an expert in virology in the same way Professor John is, but I would like to see some description as to how that number was arrived at. Is that a financial decision? Is it based on some kind of a modeling exercise? And if yet, what are the assumptions behind that modeling exercise? It's clearly the case that the government has to decide with a strategy, and they have a limited number of doses to play around with because there's been a global inequity. We know many countries have already pre-bought a lot of doses. So is it a function of what the government thinks it can afford and what is available, or is it based on some kind of an exercise where it feels that 30 crore is some kind of a magic number where we will be able to change the pandemic direction in a way that we don't really need to vaccinate more people? I don't know of any evidence which indicates that you can come up with a number like that. I would have thought that the focus would have been to vaccinate more people, because even with existing vaccines in our universal immunization program, we haven't reached optimal coverage in many parts of India. In many states, it's actually quite disappointing. And the data is out there in the public domain. So if that is what we need to run with, and here we are talking about a vaccine which needs to be given to a totally new set of population, in many cases, adults who've never been vaccinated at this scale before. You need vaccinators, you need financial resources, you need syringes, you need the infrastructure. It's certainly going to be a challenge. So even that 30 crore will take a fair bit of time to reach to, but the larger picture being, we don't really know how things will shape up. Maybe the pandemic is on the wane already in some countries like India, but then you have concerns like in this week we've been talking about the mutant strains, and does that have an impact? We'll have to wait and watch. So I don't know of a justification for that 30 crore number. Maybe there is something which they have discussed internally. Hopefully that will be made available in the public domain for all us to be able to make judgment about. But I would tend to think that you would try to maximize your reach in a way. Again, as was being pointed out, that you have surveillance at the same time, good quality surveillance, public health surveillance, genomic surveillance, which is keeping on telling you what is your success rate like. Are you really bending the curve significantly enough that you can then obviously recalibrate your vaccination drive, and that is going to be real-time efforts, and hopefully we'll see more of that as well. So with the logistics planning, we need to have simultaneously that surveillance planning, and that data should be in the public domain. And linked to that is keeping a good track of adverse events following immunization. I know they've talked about the fact that they're going to track that, but then what do you do with them? If there is an adverse event, do we just, what is our responsibility as a society to those individuals? These could be health workers in the first wave, because health workers are the first group of individuals to be vaccinated. What if something were to happen to one of our colleagues, an adverse event? How would you like that person to be treated? Would you want that person to be provided all kinds of medical care as required? Would you want that person to be compensated? And if that is the expectation you would have for a fellow colleague of yours, why should that not be true of anyone else in the general population? So I think all of those are the other things we would need to have more clarity around, so that, again, it goes back to that trust question that we started with. It will build more trust if people feel that I'm willing to participate if there were to happen something to me through a public health exercise, that the government will take care of me. And I think that is also important.
Yeah, David, that's a very important point. If side effect happens, is there any mechanism of compensating such individuals in United Kingdom? What does US follows, and what is the UK strategy on compensating the individuals if any serious side effects happen, maybe because of the vaccine, may not be because of the vaccine?
Thanks, Abdul. Yes, these rare events that happen only show up after a vaccination program is begun. And back in 1976, I'm sure many of you will remember, that was actually the year I started at CDC in the US. And in 1976, the US had just been vaccinated for what was thought to be a pandemic influenza virus. It was an H1N1 virus that was isolated from pigs. The whole US had been vaccinated, and all of a sudden, several months afterwards, people began to develop a rare side event called Guillain-Barré syndrome. As a result, the US government had to set up a compensation fund, and the manufacturers of vaccine actually left the US for several years after that in order not to have this liability which occurs after a vaccine has been developed. The UK has talked about various funds. What's even more important, though, I think, is what the COVAX facility is doing. And as you know, the COVAX facility is part of the ACT Accelerator. And this has as an objective to be sure that there's enough vaccine to be equitably distributed throughout the world. There will be countries that receive vaccine free from COVAX. There will be other countries that purchase vaccine at a much more low rate than they would if they were purchasing it on the open market. But no matter what, the COVAX facility through WHO is requiring that countries have their own litigation means to protect their own citizens should this vaccine be used. And I'm sure that there have been considerations in India. Dr. Bhan would be able to talk about that, I'm sure, whether or not there will be litigation in India that will provide for people who have had adverse effects. He's talked a little bit about that previously. And I think that all governments are concerned about this. So yes, there have to be funds that compensate people if these rare events do occur, or in fact, if any serious event occurs from the vaccine which was unanticipated. Over.
Anand, Dr. Bhan, what do you think, what is our government strategy is going to be on this compensating the individual with side effects? Has the government got any plan of establishing such a fund, or are we going to ask the vaccine manufacturers to compensate the individuals? What's our plan?
Yeah, I don't think there's been anything declared so far. I hope that is something that they are considering. In our past experience with EFIs, in fact, any major adverse events caused due to public health campaigns, even sterilization for that matter. We all know, sterilization was a big focus in many places. It's still a big focus, and sometimes mistakes happen, and there are, serious adverse events. There are sometimes deaths. But it's often the case that, it just gets lost in, you have delays, you have reports being written, the family doesn't get a lot at the end of it. If they're lucky, they might get some medical care. And if they are insured, maybe they get some money, but usually you don't get anything. We also know that this has happened with us. We also know that you have vaccines for polio, etc., where there are vaccine cases where there'll be some people who have polio because of the strain of the vaccine. And there also, I think, there's been no case. And I think it's important for us to have that clarity, because I think it's important for us to recognize that this is a public health exercise, and anyone who potentially undergoes a risk or an adverse event caused due to that public health effort, we cannot shy away from the fact that there is a possibility of adverse events happening, especially now with these vaccines where there's not been enough time to study long-term safety. But if that were to happen, I think I would want to have clarity that there is a way for the government to take care of those individuals. Primarily medical care, but if required compensation, I think that'd be good to have that. I hope that that's being actively considered. That's my opinion.
Dr. Ghafur, sorry to barge in.
Yeah.
We are about an hour into the program, and maybe we have another half an hour more. There are
Sure.
lots of questions in the chat box and the Q&A.
Yeah.
I was wondering if it's
I'm
okay.
reading. I'm tackling those questions one by one. Actually, most of the questions are from the chat box.
And also, there's a Q&A box which has more questions. Thank you.
Yeah. One question is to Professor Jacob John. So you mentioned that we may not have to vaccinate the antibody positive individuals, but don't you think it's logistically very difficult for any country to do antibody testing first before vaccination? One recent US model in mathematical modeling suggested that you can defer the vaccination of individuals in seropositive individuals, and you can first select high seroprevalence groups, do antibody testing, and defer vaccination of antibody positives. That can have a better mortality reduction as a public health strategy. But isn't it logistically very difficult to do antibody testing even in high seroprevalence areas and groups?
Yes, the question is theoretically important, but in terms of practicality, to test people for antibody and separating the antibody positive and negative for vaccination is not a practical proposition for various reasons, including the fact that antibody levels decline quite markedly after intervals of 3, 4, 5, 6 months. So antibody, although it is a theoretically good way to separate those who need vaccine and do not need vaccine, I don't think that is going to be very practical. However, people know if they had been infected, because the testing has been done either by the government system, therefore the entire database is available, or through private sector and the database is available. So there should be an agency that collates all that and allots vaccine to people who have not been infected, but they come into the group of the target group. In the UK, I recall that by mid-2020, they already had names of people who should be given the vaccine first. They had a list of 300,000 people at that time listed. And so when the vaccine was registered on December 1 or December 2, those people got the vaccine first by their numerical order 1, 2, 3, 4, 5, 6. We don't have anything of that sort at all available. So we have to, the government has to plan ahead in terms of, this is an unprecedented situation. Very interesting moment in history of vaccinology for the government to actually put their act together in terms of clarifying these questions themselves. If we don't, there'll be quite an anarchic way of distributing the vaccine. And there'll be huge wastage, and we may not get vaccine to the right people. People who are a little more pushy may go and get the vaccine. They know the ropes, whereas the really needy people may not know the ropes and they may get left behind. So this whole thing has to be thought through by either Niti Aayog, Ministry of Health, or the disaster management group who is the spearheading, or by an independent group. It has to be done. There is no way you can avoid that kind of planning. Okay, so antibody and vaccine is probably a non-starter, but knowing who was infected in the past and then leaving them for the next round of immunization after everybody else is covered is a little more practical way, but that database is available in the computers of both the public sector and the private sector because everybody has been tested. You know, the number of tests being done was a phenomenal number. Okay, you can multiply the 10 million with 100. Okay, so 1,000 million people probably have been already tested. So we have the data available. Still, it's a call to be made by the planners of the immunization program if they are serious about giving the vaccine in a logical, rational, need-based, and fair manner. Back to you.
Thanks, sir. Dr. Heinemann, we have got multiple questions on the vaccine efficacy and the new UK variant strain. Have you got any preliminary information from your virologist from PHE on that?
Well, actually, just before this conference, I was at a WHO meeting and the new variant was discussed. And as you know, this new variant is present in the United Kingdom. It's also been identified in the Netherlands, in Denmark, in Italy, and there's a very similar version of the virus which has been identified in South Africa. These viruses appear, and I say appear, to be transmitting more easily than do the other viruses. So it looks like they might be more fit. They might be able to adhere to the receptor easier than do the other coronavirus, SARS coronavirus 2 strains, but it's not yet clear. What's being done now are two things: trying to sort out the epidemiology, that is this increase in cases of this new virus due to super spreading events that then spread it further? And this is one of the hypotheses in South Africa, for example, that at the end of school, increased transmission occurred, and this was the virus that was increasing in transmission. But it appears that the virus may have a reproductive number that's maybe 0.4 higher than the known SARS coronavirus 2, which has a reproductive number of about 1.1, meaning that about 15 people could be infected from every person who's been infected. So that's still being examined to see what's happening with that virus. The other study that's going on is a neutralization study in the laboratory to see if this virus can be neutralized in the laboratory by antibody that's been produced both by natural infection and by immunization, which is of course very important because we want to see if the current vaccines are actually protecting against this strain. There's no evidence yet to show that this virus does not respond to the vaccine. There's no evidence to show that disease is more or less serious from this lineage of virus. And there's also no evidence that's firm to show that this virus is transmitting easier than other viruses. Although the evidence points to there being a link geographically with increased transmission of this virus. So a lot is going on. And within the next week, we'll learn much, much more about this virus. I don't know if that answers the question, Abdul. If there's more, I'd be happy to answer.
Sure. Dr. Ban, do we have any idea which vaccine our government is going to introduce? Is it going to be 1, 2, 3, or 5?
Yeah, so my sense is that we are in for a phase where the government will try to maximize, which is to say that have more candidates in the fray and see whichever set of vaccines passes their standards from a regulatory process. Obviously, it's quite keen on Serum, Oxford. So that's certainly one which is right now obviously being seriously considered. The Bharat Biotech ICMR one is the second one. These are the two front runners, I guess, for if any of them were to be licensed early. Pfizer, I don't think necessarily is being considered for the public market. I don't think the company by itself is also maybe very interested in the public market. My sense is that they may be more interested in the private market, also because it's going to be very difficult logistically for it to be used at scale in India, given the costs involved and also cost of the vaccine and the cost of setting up the logistics. So I guess it's going to be these two vaccines in the fray, and then you have Novavax, you have Cydus Cordilla, you have the Indian mRNA vaccine as well. So I think there's going to be a whole line of other contenders, but that's going to be probably the second phase of vaccines. If any, these are probably the two front runners. And we'll have to wait and see when there is enough data for that to be given regulatory approvals. And hopefully we will know in the near future. I mean, the first round, as we all know, they were asked to go back and bring more data, which I think was the right decision from my personal opinion. But we'll have to wait and see what the second round of applications will bring through.
We have multiple questions on, can we give vaccine to pregnant and immunocompromised individuals because they were not included in the trial? So what will be the recommendation? I'm sure, David, the UK have already published the recommendations. You have already initiated vaccination. Are you vaccinating pregnant and immunocompromised?
At the present, they're not being vaccinated, but what will happen in the studies is that there will have inadvertently been women who were pregnant who were vaccinated, and that will be a first step in understanding the safety of this vaccine rather, in pregnant women. So there's a whole series of study that needs to be done, but at present, there's no recommendation either for or against, and I expect that pregnant women will be vaccinated with this vaccine.
Thank you. We do have a very interesting question. Do all adenovirus vector vaccines enter the host cell as episomal DNA, including COVID, or there any chance of integration into our genome? Dr. John? Professor Dr. John? Will
Yes.
the adenovirus vector vaccine get integrated into our genome?
What about adenovirus vector vaccine?
Will they get in will the DNA? Do all adenovirus vector vaccines enter the host cell as episomal DNA, including COVID, or there any chance of integration into our genome?
As far as we know, there will be no risk of the DNA, which is the transcribed complementary gene of the RNA virus, integrating with human DNA at all. There need not be any fear, because every time when we get infected with some virus, we are getting the viral genome in huge numbers in the body, and they don't integrate with our DNA except the HIV virus. It's reverse transcripted provirus DNA does get integrated in the human chromosome, and therefore it is not going to be easy to get rid of that virus. It will be with us. Now, that is a retrovirus. Many of you may not know that a huge proportion of the human genome is made up of DNA that we received from past retroviral infections during the process of evolution. And some people believe that such contribution of the DNA has helped us develop our frontal lobe so that we are human, developed our vocal cords that we can speak, which our nearest cousin, the chimpanzee, which is 1.4% different from our genomic structure, do not have. So, however, no fears about the the genome getting integrated. This is not like genetically modified products that we are little careful about. Not at all. This is like another infection that the body will look after the infection quite well, except for retroviruses.
Thanks, Professor John. So we don't need to worry about this genomic integration. Whatever is being spread through social media on this integration is scientifically incorrect. That's very reassuring news. I have an interesting question from one of the participants. Will we need to change our testing strategy after the vaccine is introduced?
The testing strategy means actually for the virus, like RT-PCR or antigen testing, that kind of a strategy. That's a very good question. And that is where public health actually comes into reality. The management of information, monitoring of the trajectory of the incidence of the infection and the overall community immunity level, all these are a matrix which has to be clearly described by the public health department, which we don't have in India. So what will change? Infection will continue, and therefore testing has to continue. The vaccinated people's protection level has to be monitored. So they have to have some kind of follow-up, whether you call it as a post-marketing or phase 4 trial, that has to continue for quite some time. So yes, we are entering into a totally new new waters, which we have not got any experience of negotiating in the past. So again, deep consideration and strategy, tactical planning, and of war room strategy planning are necessary as you change one ingredient, namely introduction of vaccine, which will alter the equation of the virus-human interactions. Important question. We don't have an answer right now. It is something to be carefully planned.
We have got a question from a pediatrician. How are we going to address vaccinating children when the infection seems to be milder in majority of the children, but these children are the potential carriers of the virus? So what will be our future strategy of vaccinating the children? Are we waiting for trial evidence in using this vaccine children?
It's a very good question. And as I'm sure the person who asked the question knows, the younger populations seem to not be as susceptible to infection, possibly because they have fewer receptors on their cells. It's not clear why they're less susceptible to infection, but they will probably respond to a vaccine. And the question is, are they a priority for vaccination? At present, most evidence says that they're not. It doesn't appear that children are the source of infection in their households, although occasionally they do infect others within the household. But it appears that children are not the carriers of this virus, as they are for influenza. As every pediatrician knows, children are very important carriers of the influenza virus into the household. And that's why elderly must be very concerned if children are coming home from school during the influenza season and they're not vaccinated. And so many countries now are recommending influenza vaccine for younger children. But for coronavirus, SARS coronavirus 2, the answer is not yet there, but most countries are not vaccinating children as a priority because of the fact that they do appear to be less susceptible to infection and less the source of infection to others. Over.
We have so many questions on comparison of various vaccines, but too many questions. Probably we will, comparing advantage, disadvantage, and side effect profile of individual vaccine needs a separate Zoom meeting on that. And is there any other interesting points, important points our expert panelists need to share with the audience? India is going to initiate the vaccination most likely end of next month.
May I speak?
Yes, sir.
I was saying that pregnant women is a special class, and we need clear evidence that it is safe in them, particularly anything that contains live virus material. Okay. Whereas the inactivated virus, you can be a little more confident, yet we need data to show that. Now, David mentioned about children. I would draw that line about 10 years and below versus adolescents and college age. And they are as susceptible as adults, and they, as you have seen in university campuses. So, yeah, I would make that distinction of below 5, definitely. Below 10, probably. Above 15, definitely in the adult group. Between 10 and 15, you have a gray zone.
Thanks, Professor John. Dr. Ban?
Yeah, maybe the one thing I want to add on is, while we're discussing vaccines, and there's been a lot of, focus on the strains, these are kind of fancy terms which catch currency very quickly on social media, on media channels. But at the end of the day, what drives the pandemic is not necessarily a virus or its mutation, it's human behavior. And I think that is something we have to keep coming back to. Even if we have a vaccine, there will be a lot of time required for us to reach that herd immunity that we kept talking about. And hence a reinforcement for the need for a caution is extremely important. And that is true before vaccination, that is going to be true after vaccination. And I think that is what we need to be more worried about in India right now as well, because we're seeing a lack of adherence to public health measures already. We are lucky that we haven't seen a post-Diwali surge, but countries, there are multiple countries where there's been some kind of a lull, and then you again have a resurgence. As we've seen in campuses, there's still a case that there are a lot of people who are still susceptible. So, it's important for us to keep reinforcing that we need to follow those precautions, even when vaccination is on, even when you have received the vaccine, because we might not know enough. And I think we have enough evidence that these public health precautions work. And hence, we also need strategies to address health behavior and human behavior, which can cause risk mitigation. So I think that is something which needs to go on. The vaccine is not a replacement for that. And I think all of us need to agree to that.
We have a very interesting last question, but that's very important for Professor Chakrapani. If the virus develops major mutation, do we have to wait again for 9 months for the vaccine against the new strain? Or can we just tweak around the vaccine but to new strains and introduce it without new trials as we do in flu vaccine?
The answer to that has come from the mRNA vaccine manufacturers and developers, who say that they can modify their vaccine within a month or a month and a half to make it meet the new standards. So I think we're pretty certain on that. But Abdul, I'd just like to summarize a bit on vaccines, because I think it's really important to keep clear in our minds that vaccines today have been studied against an endpoint of disease. So we know they prevent disease. Once we understand whether they protect against infection and against nasal carriage in the nose, then we can begin, as Jacob said, to think about the public health use of those vaccines, whether or not they can be, whether or not they have long-lasting immunity, and whether that immunity can have an impact on herd immunity and decrease transmission. So we're still, by being in such a very interesting position to have so many vaccines, there are still many questions to be answered. And for now, those vaccines will be used to prevent illness and to protect healthcare systems. And then eventually, as Jacob says, there will hopefully be a public health use for them that can really decrease transmission in the community. But I think that everyone agrees that this virus looks like it will become endemic. And a vaccine is just one of many tools that we will need going forward. Over.
Professor John?
Let me, you fleetingly use the word silent carrier. If you vaccinate, did you not? I thought I heard that. If you vaccinate, would you convert a otherwise person who would have manifested disease now would not manifest disease, and therefore he would be a greater risk to the community? That actually is a myth, because most vaccines only protect, as David said, against disease and not against infection. Even influenza and possibly the COVID infection. One infection may not protect against another infection per se, but when you get infected, you will not get disease because you're immunized. So that natural immunity is mimicked by the vaccine. Therefore, I don't think we need to worry that by vaccinating, we are creating a special class of people who would be silently transmitting infection to others. No, not at all. Okay, over to you.
Dr. Vijay, you have to make any concluding remarks?
Hi. So I would just like to wind off thanking all the panelists. It was really a power-packed session. Still a lot of questions need to be answered as we go. I think the things evolve. I hope we can come back in a month or 2 months' time with part 2 of this webinar, and we can relook at what has happened. So I would thank everybody for taking their time out. I would thank all the participants for being part of this. This session would be recorded and would be available on GCCMC website. Everybody would get a link of that, which can be shared or used further. Thank you all. Thank you one and all. See you again for the next event, which is planned on January 6th. We will get 6th.
January 9th.
Sorry, January
9th.
Yeah, sorry, January 9th. Thank you.
So on January 9th, we're having a very interesting section on how to cope with the post-COVID scenario for healthcare workers. What are the things available? What are the avenues available? Again, without the pharma, without any industry backing, with the kind of support that wonderful people have come. Just like today, thanks. Thank you, Dr. Ban. Thank you, Dr. Ghafur. Thank you, Dr. Heyman. And thank you, Dr. John. It's been such a wonderful, wonderful deliberation. Vijay, for you to close. Thank you.
Yeah, thank you. Thank you, one and all. Thank you.
Thank you very much. Yeah, bye.